Notice the guy right in the front in the center. That's John Haas, who's the president of the National Catholic Bioethics Center that's based in Philadelphia. And the background there is Charles Borromeo Seminary, where we met. It seems to me that a quick way to summarize what we were trying to navigate was to recognize that there are two extremes that we wanted to avoid. And on the one hand, one extreme is just being rash and, kind of just diving in full dose medications without good evidence, without a sense of, what are the appropriate criteria for applying this. And it may be that in the case, that third case of existential suffering, maybe that was a rash decision. The other extreme would be to be overly hesitant, so that there are people having genuine distress. The first case, somebody having, they were partial seizures that were just annoying and frightening. And it was actually, the medication in that case is actually being used to treat the seizure. I mean, that's an appropriate treatment for the seizure. And in that case, it happens to be a sedative. So it does have some of that double effect. But one would not want the family to feel so constrained and guilty about these moral issues that they wouldn't actually provide that appropriate intervention. So that's sort of the other extreme. And I guess the one sort of image that I have from Philadelphia, after a long day of debating sedation and the issue of hydration and what should Catholics think about this, John Haas took us to a very nice pub in Philadelphia, and everybody was drinking away some very fine beer, and he said, the Catholic position on this should be quite clear. You can have both sedation and hydration. One other point I would just make, I guess Moira was mentioning my involvement with people with intellectual disabilities. And we produced a book last year, and one of the topics that was addressed was called rapid tranquilization. This has nothing to do with palliative care, but it's the same drugs, and it's used in the context of often somebody with autistic spectrum disorder who becomes very distressed. And it's a way of kind of providing safe medications in an emergency or crisis situation rapidly and safely, and all the appropriate monitoring. So it's sort of a broader issue, but these medications are very commonly used. So I'm just going to kind of highlight some of the things that you can read about in more detail in the paper that we've provided. One of the things that we try to do is just say, we're struggling with these issues, and can we articulate some basic principles to guide our thinking? And an important one is intrinsic dignity. And so some sense of human dignity and the importance of care in that context to actually improve the life and condition of life of people who are seriously ill and dying. And that's a matter of dignity. Another point, of course, was there are violations of dignity, and intentionally hastening death is a violation of human dignity. Another point that came up, and this is actually under, I think, a very important point. If you have a chance to read the statement, it's actually under point number 9, and it's in a reference, and it's sort of an articulation of basic standards of therapeutic interventions, and what are the norms for those. And one of those norms is proportionality, but there's a number of them. Another important one is discretion, to have a sense of when, what the limits of medicine are. And I guess the point is that there is maybe a position that's in the background here that there are different norms that apply when somebody is dying. And I think we very clearly said, no, there aren't different norms. The conditions are different. But the basic norms of any therapeutic intervention should also be continuous as people are at the end of life. Number 6 in the list of principles speaks of the unity of the person. And this notion, that we are a unified whole, and to kind of think of that as, a principle of care as well. So not only are approaches to care holistic, recognizing the diversity of the human person, there is also the notion that we shouldn't reduce people to one function or aspect of their being. And there is, I think, a tendency to reduce the human person to their kind of cognitive abilities. And that's why some might say that there is sort of an absolute prohibition against reducing consciousness or awareness. And so that could be actually a symptom of a certain reductionism. Another important principle, it was actually articulated in number 7, was this notion that life is finite. Even lectures are finite. And that in this finitude, our goal is to find meaning and hope, even at the end of life. And the importance of awareness in the context of dying, even at the end of life, from the point of view of spiritual preparation for death. And some people that, that third example, I think it was mentioned that this person didn't have any sort of spiritual perspective. But in a sense, we are all part of the same universe, and these are universal issues to grasp with, and that to see awareness as a condition for that sort of preparation. Another important thing, and I think a corrective to some of the autonomy that is a very powerful notion, is that we are all relational beings, and to recognize that and support it. This notion of solidarity and trust and communication. So the examples of so many physicians not even discussing this with their patient, and not even the family, when these very major decisions are being made, goes against that notion. There's also the notion of supported decision making. Many people that are seriously ill and dying will not be at their brightest, and these decisions will require support, and that's part of being a member of a community. There's also a notion of justice, considerations of the common good, protection of people who are vulnerable, a big concern here. Now, we try to end these things not on a high level of principles, but on some very practical considerations and recommendations to get people thinking about what they can actually do. So I'll just kind of quickly highlight some of the recommendations, but you can read them more amply on your own. But I guess the first principle is, that such people should have adequate care and assistance for their symptoms and distress throughout their illness. And this may well include the appropriate use of sedating medications. And it is important to have some sense of criteria for their use. Maybe we call them indications that are agreeable and acceptable. And one of the things that's commonly referred to is refractory symptoms and distress. And by that, it's commonly stated that other available means are ineffective and do not provide relief within a reasonable period of time, or they somehow, these other things may well just exacerbate the person's symptoms. And that this symptom is just intolerable. So that, this is a concern, and it kind of, this gets to the sort of the limits of how we're able to care for people that are very distressed. So the recommendations, these are, again, just a few highlights. they're not restricted to people in the last 2 weeks of life or that are called imminently dying. It's a much broader perspective that we are envisioning. I guess the focus would be on the actual needs and goals of the patient and family, and so it's meant to be sort of very person and family centered. An important point is that we are not dualists, or we tried not to be dualists, so that there wasn't an effort to distinguish sharply between a physical symptom and perhaps a psychological or spiritual level of distress. Again, it goes back to this notion of the unity of the human person. And so we didn't distinguish sharply between those symptoms. And that's why this issue of existential suffering is a real concern. And while it may not be a physical symptom, it is certainly a cause of distress. And so we tended to use that term, distress. And that the use of these medications could play a secondary role in addressing people with this non-specific existential suffering. And this notion of intolerable, it leaves room for variability in patient responses to symptoms and distress, as well as to personal goals. So that the recognition that ultimately what you call refractory and intolerable will be very much determined by who you are and just how you're able to cope with life at that stage. As mentioned, the use of sedation should be proportionate, and so that principle is very important. It's proportionate to the demands required by the patient's presenting symptoms and level of distress and ongoing condition and response. And so it was meant to be that these things were not kind of rashly given in kind of high doses with no monitoring, but that they were proportionate and used in that context. There was the question of this immediate sedation to the level of unawareness, and that we did not want to say that that's not ethical, that for sure may well be a last resort, but it may be necessary in certain conditions. But in most cases, this notion of proportionality and gradual titration with documentation and monitoring would be appropriate, just as we do for people with autism that are very distressed. And it certainly, the statement and the group would accept that it may well be the case that people with these sorts of interventions would in fact die unaware, right? That tricky issue of sedation and hydration was one in which we thought that there was no direct connection between these two issues, that those were in fact separate issues, that the issue of hydration and nutrition had to be considered on its own merits. And that is in the context of many protocols that will say that in fact, you do this, you stop hydration. We did not agree with that. But we wouldn't say that you always have to sort of ensure that somebody's dying with, proper electrolytes and so on. So I guess just some of the other considerations that are raised, and then I'll just list a few of the questions that we didn't actually settle on. There is an issue here of sufficient resources, and really the focus tends to be very pharmaceutical, but there are many resources, especially for people with existential distress, for which a pill is not the appropriate response. And so that is highlighted strongly. The importance of education, so that people have some awareness of proper indications and the ethical use of sedation in these contexts, the very important interdisciplinary nature of caring well for people that have complex things going on. And then the importance of early and ongoing communication among all the people that are stakeholders, patient, family, care providers, and to support them in decision making. Just as I came in, someone was mentioning about some advance directive that people are asked to sign when they get admitted to certain long-term care facilities that will list these things. Well, this is not so simple, right? You know, to figure this out, and that any such directive should just be kind of the conclusion of an adequate discussion and helping people to understand what the issues are. So, some unsettled questions. And it's fine to have unsettled questions. In fact, you know, whenever we meet and come up with something, we don't meet for that long. And there's basically a date when we kind of sign off on it. And it's a group of people, and that's kind of the best we could do in the time and with the information we had. And so we would expect there's lots of room for further discussion. But what we try to do is kind of develop a bit of a framework for those discussions to happen and encourage people to go back and have those discussions as we're having tonight. So one question is this question, is this a moral evil we're talking about? To directly intend to make someone unaware, so immediate sedation to unconsciousness, even when that's used as a last resort. Is that actually you know, an intrinsic evil in the old moralist language? Because it is a direct intent. It's not an intent to kill the person, but in that cognitive sense, that's the end of their life. Another question was, and so just on that question, the group was not in consensus. You know, and another one, may one progress to deep continuous sedation for exclusively or primarily non-specific existential suffering? We did not kind of come down on that one. In other words, it could be foreseen, and again, we're talking about seriously ill and dying people, and the distress people have are of a variety of types, and so in that context, and it was the third case, would we say that that's always something that should be not done? We essentially qualify the answer by saying, you know, that really is a last resort, but we wouldn't rule it out. And then the other question that was left unsettled was this question of intermittent deep sedation. So in other words, putting somebody to sleep with these medications and then waking them up, checking in, how are you doing? Really bad, putting them back to sleep. So, I mean, the group felt rather uncomfortable with that as sort of a recommendation that everybody should kind of follow such a pattern. So, I'll just conclude by referring this, or kind of looking at what we came up with in the context of another, I think, excellent document that Blair Henry worked on, who many of you know. And he actually wanted to come tonight but couldn't. But this is a much more clinical treatment of the issue. And in many senses, it's this sort of kind of clinical framework. And even that, they just call it a framework for a guideline, right? In other words, but it is much more clinical in its focus. But it's restricted to the ethically controversial issue of continuous sedation. And normally when people say that, it means continuous deep sedation. And they also qualify the whole framework to these last 2 weeks of life. So it's a much more sort of restricted range of issues that they're addressing. And you know, we can talk about why 2 weeks, but I think it's the hydration issue. One of the very, I think, helpful things is it does provide specific clinical guidance for people on kind of decision making and so on. that this notion of interdisciplinary assessment of refractoriness and intolerability. How do you actually sort that out? It's making some very specific recommendations about medications, which we actually didn't get into. Most of the group, we're not, really expert in that area. But they actually point out that we're not talking about opioids when you're talking about sedation, although some opioids may have a bit of sedative property. And they're not talking about another antipsychotic called haloperidol. Or at least they say it should not be used. So they're making some fairly specific pharmacological recommendations. They also talk about scales that would be appropriate for monitoring people's responses. And again, these are, I'm just going to end on these sort of questions that we dared not make a statement on, but they did, it would seem. So this whole question about kind of directly intending unconsciousness by, say, use of immediate sedation to unconsciousness, should that kind of be off the table, that sort of approach? And they did not think so. They didn't think it hastened death. Is that right, John? And they didn't really think it was a relevant ethical issue. The other question was about progressing to deep continuous sedation exclusively or primarily for this existential suffering. And they said, yes, that is appropriate. And then the third question about intermittent deep sedation, is that an appropriate practice? And they basically said it's unlikely to be beneficial. And again, they're talking about the last 2 weeks of life, either for the patient or their family. So interesting to kind of compare the two documents. We didn't work together, but I think that what we've provided is probably a sort of a much more of a philosophical framework and kind of Catholic perspective on these issues, and with the intention that these sorts of details would flow in at the level of kind of policy and so on. But that is the important, certainly the important next step that needs to be done, and I think they did, quite a good job for the most part. So on that, I think I've hopefully not gone over my 15 minutes. So maybe we'll just open it up for a little discussion.
I'll just take the questions.
Okay. Father Miller.
One of the cornerstones of Catholic thought on this is the whole position on intentionality.
Yes.
And one of the things that has really struck me is how little that is understood in the medical world, particularly among physicians, and how often, for example, there are surveys done of physicians about euthanasia at the end of life. I remember even one back in 1994 in Alberta. 25% of physicians thought killing people at the end of life was a good part of medicine. And the intention was precisely to kill people. And what I find very often is that the whole approach towards, I think John mentioned that idea that the consequences of whether your intention is to kill somebody or the consequences are the same.
Yeah.
So what's the big ethical difference?
Yeah.
And you'll see that in the Carol Taylor case
Yes.
in Vancouver at the present time. And I'm just wondering how we can get this whole notion of intentionality across more clearly, because to me it's critical to the whole thing.
Yeah, well, John, maybe I'll let you say something about that, but I think that that is a very important part of the sort of approach to these questions. And it's true. Not everybody accepts it. And, when people say, so what's the difference? The outcome's the same. That's the consequentialist approach. And so it is, I think, very important. The other thing about these surveys is that by not paying attention to intention, many things that we think are quite appropriate, they think you're killing the person. Right. So withdrawing things, they include that. Like many people, if intention is not important, it's all the same. So yeah, it's a very important and very basic, I think, point that needs to be made.
Yeah, thank you. Just on that point, I mean, I agree, Mark, it is about intentionality along with a few other things, but intention in this particular case. And so this first statement here, and I know what you mean is directly intending unconsciousness and not just directly intending unconsciousness, because clearly that would be a moral evil if that's what you were saying. But to relieve pain is directly intending unconsciousness with the intention of relieving pain, a moral evil. And that's what Pius XII said exactly. It was not a moral evil if the intention is to relieve pain. And he was very clear on the point of suffering, and even referring in a sense to that existential side, though he did not use that word. But he was also very pastoral, I think, in saying that even to the level of unconsciousness, if that's what was necessary to relieve the pain, and that was not a moral evil. He didn't make it a kind of, yes, and John was saying that too, but just to emphasize a bit about intention. So the unconsciousness, if you like, is yeah, you know that will happen, but what you're really trying to do clearly is to, relieve the person from pain. But he also said too that we needn't choose that. I mean, the important thing here, and I think you're referring to it too, and John was saying a little scary point about the decisions not having the involvement of the patient, or, so I mean that's clearly unethical in any event. But Pius XII was saying that one could choose to unite one's sufferings with Christ.
Yes.
But if and this is where that subjective side too that you're mentioning, I think, is it's also extremely important, comes in. If the pain is intolerable to a person, and that will vary from person to person, then he was saying there is no kind of moral difference between the two types of person, even if one chooses to unite one's suffering with Christ. But if one chooses even to the point of unconsciousness, and he actually said, even if it hastens death. So he covered all the bases way back in 1957, or at least in question one. So.
Did you want to say anything?
Yes, well, there are many issues, I suppose, that have been sort of very neatly brought to our attention here. Before I sort of add my few comments here, I'd like to recognize Dr. Anthony Kerrigan, who was part of our discussions in Philadelphia. So at any time, Anthony, if you'd like to contribute to some of these answers, please feel free to. On this last point, and then working back to Mark Miller's question about intentionality, with respect to what Moyer had said about Pius XII, I think we really do need to go back to that statement, even though people argue that he's speaking in a very specific context with respect to the use of anesthetics in surgery. There are moral principles there that we can draw upon to apply to this contemporary situation of palliative sedation. And particularly this criterion of tolerability of symptoms in the patient, which is a very patient-specific variable. I think often many of these guidelines with respect to palliative sedation leave out. They will say palliative sedation is appropriate ethically if there are no other available means to address it. And they don't touch upon this other criterion of, well, how much is the patient and the family able to tolerate of the distress? And tolerability really connects to Moyer's point. Pius XII, not only in that context, talked about the meaning and value of suffering for the Christian, although it did not make it a moral obligation for one to unite oneself to the suffering of Christ in that way. But to realize that individuals might have personal goals that might make the toleration of pain and distress much more bearable than for others. So not simply just in terms of the meaning of suffering, but just in terms of perhaps they want to retain their consciousness in order to interact with their families for a longer period of time, for example. So it's a balance between burdens and benefits, and I think what we emphasized at this colloquium is a proportionate assessment of the ethical acceptability of palliative sedation has to be tied always to the concrete actual needs of the patient and family. With respect to intention, yes, I think it's correct. This is a very important moral issue, not one that others in society necessarily agree with. In other words, the significance, the ethical significance of intentions. Interestingly enough, legally, it seems to be a well-established principle. If you look at all the legal judgments that are important in the area, for example, of euthanasia. So, for example, the judgment in Sue Rodriguez a number of years ago, specifically, the majority decision cites terminal sedation and then says we must maintain this rigorous boundary between the use of terminal sedation and that it is legally and morally different from euthanasia because of intention. And intention is fundamental in the way that we judge culpability for crime. So in the legal context, it seems to be a well-established principle. The Senate report on end-of-life care in Canada also sort of highlighted the importance of intention when we're trying to distinguish between ethically acceptable palliative sedation and euthanasia. But medically, it's not always the case. As Bill said, there is the prevalence sometimes of consequentialist thinking, and then also there's also the whole practical question of how how you articulate your intentions. So doctors may not even be clear what their intentions are, or be able to express what their intentions are in terms of using sedation. So so you need to be kind of wary, or not wary, but to judge not simply by what people say their intentions are, but also the way that behave. For example, the dosages that they use, etc., to gauge what intentions are.
Great. I guess one of the other reasons why this, I think, whole discussion is important is the Carter case in BC, and many people in the medical community think that it's inevitable to result in a change in the law of the country, and that's a huge issue, and it'll have huge impact, I think, on Catholics involved in healthcare. So it's something that I think that this should be considered kind of the beginning of a much longer and focused discussion that would actually hopefully rally some kind of energies into sort of articulating these important issues in a broader context. Now maybe, Tony, did you want to say anything about the colloquium or anything else that we misrepresented from that?
You made a very interesting comment on one of the comments, but a shifting of phrases during your talk when you went from sedation to sedating medications. And I think that's more than just a choice of words. I think it's a fundamental difference in approach. And it's something that I think Dan in Philadelphia remarked on him. He used the word sedative palliation rather than palliative sedation.
Right.
And at the time I thought it was just semantics, but on reflection I don't think it is. I think the risk in this is we end up with a dichotomy. We do palliative care, then we do palliative sedation. And that's the risk. And the truth should be that it's all palliative care. And it's simply that this is a form of palliation using sedative drugs.
Yeah.
And I think that point really has to be made. And it comes back once again to the question of what is the intention? Is the intention to relieve distress and symptoms, or is the intention to induce sedation? And I think one has to be clear right at the start as to what you want to do.
Great.
Well, I think we're getting close to the close, but we're going to hang around if people have other things to discuss. I guess I'd like to, yes?
Just a comment. In the way you were identifying some of the things from your colloquium, like intrinsic dignity, unity of the whole person, human finitude, relationality, justice. Isn't that what most physicians try to do with patients every day when they see them? So it's relevant that we need to, and I don't know whether our current medical training is teaching people to develop a therapeutic alliance with their patients, to find out who they are, where they came from, where they're going, and what's the meaning of their life and all that. So, but meetings are very important, not just at the end of life.
That's right, yeah. Yeah, I'm hoping that just articulating these things would be helpful much more broadly. So I wanted to close by saying thank you to the Order of Malta. Many of the representatives are here for making these sorts of events possible, and to give a little advertisement for our next event. Again, if people remember, it was 2003 that the Order of Malta sponsored the first international event that brought together lots of bioethicists, and out of that gathering right here, there was a decision that we should keep doing this every couple of years. And so the Order of Malta has agreed to that. And so every 2 years, we've been going somewhere differently. And next June will be our 10th anniversary. And it's also a big anniversary for the Order of Malta. And so we're going to have our colloquium in Rome at a very, very nice place south of Rome, overlooking Castel Gandolfo. And it's Villa Palazzolo, if you want to Google it. But we've got the whole place, room for 70 people. And the topic will be ethics and the care of people with intellectual disabilities. I finally got it in there. So it's actually being co-sponsored by the Canadian Association, so we really should have a very good Canadian representation. So I'm sort of kind of putting out the word that start thinking of this. I think it's June 9th to 14th. And there will be, sorry?
What year?
Next year, 2013. So yeah, it'll be a lovely place, lovely time, and many, many very interesting people come to these things. So on that note, thank you very much for coming, and I hope some of you might be inspired to come to spend a week debating the ethics of caring for people with intellectual disabilities.
Thank you very much, Bill and John. It falls to me to thank you both on behalf of the audience for your excellent presentation. John, for clarifying these very difficult issues from an ethical point of view in relation to Catholic teaching, and Bill, for your summary of the IAC meeting. I've always been interested in how this consensus document has arrived, and it reads so blandly and uncontroversially, and having taken part in the colloquium on artificial nutrition, hydration, and nearly having come to blows with some of the people, I find it very reassuring how everything turns out so well. So thank you.
It's the wine.
And thank you for reminding people of the meeting in Rome next year. So thank you very much, and a small token of appreciation from the CCBI.
Thank you.
Thank you, everybody, so much for coming out. It really is wonderful that you took the time, and I think you'll agree it was a really worthwhile presentation. So thanks again to our presenters, and we will be in touch with most of you about our next events that are coming up fairly soon.
Yeah, and I omitted to thank Moira and the CCBI for hosting us. Thank you.